Sometimes people have sciatic pain, and it's a cyclic sciatica where every single time, when they're on their menstrual cycle, they have sciatic pain, but they don't have endometriosis, or they have endo, but it's not anywhere near the sciatic nerve.
Okay, so the first one is, if changes in temperature trigger UTI symptoms, could this be due to nerve involvement, or is there an infectious explanation for why that would happen?
I don't know. Good question.
Yeah, not the only person that has asked this in the past. I've never found an answer for it, but
I mean, temperature making it worse. I mean, I guess there are some bacteria that grow better in higher temperatures, but I mean, our body's pretty warm all the time, so it's hard to imagine that. I mean, the thing is that if it's hot out, your body temperature doesn't change.
Yeah.
Very much, unless I mean, if it does, then you're in heat stroke. Like, that's a pathological condition if your body temperature is actually changing.
And if it's cold?
Your body temperature is the same. I mean, your skin gets colder, but your internal body temperature, again, if your internal body temperature changes when you get cold, we call that hypothermia. Like, again, that's a pathologic condition.
Yeah.
So now there is some impact on, it's almost like a rheumatologic question that I don't know that much about, but like people that have arthritis, so they have more joint pain when it's cold. I'm not really sure why. So inflammatory conditions perhaps get worse when it's cold and get somewhat better when it's warm. Like people that have a bad back usually feel better when it's warm, and they feel worse when it's cold.
Yeah.
And they say, oh, my back's cold, but I don't really understand what that mechanism is.
Okay.
Perhaps it's just that things are a little bit more contracted, or I don't know. I'm just making it.
Speculating.
Yeah.
Someone else asked what pelvic congestion syndrome is and how common it is.
Okay, so pelvic congestion syndrome is a big kind of a wastebasket term of things, but it implies that there's vascular compression of stuff. And so the classic pelvic congestion syndrome is coming from varicosities in the ovarian veins, so the gonadal veins. And so when the patient stands up, you basically get a column of blood over their ovaries. Okay. And you almost have, like, usually you're getting congestion of the ovaries. You can get kind of a dull aching pain in the pelvis radiating into the back. And you can also get congestion of it's sort of like the venous drainage. I mean, I guess the easiest way to explain it is that if you've ever know what varicose veins is, where your legs feel really heavy and your legs feel painful, and it's because you don't have good valves in your legs. So when the blood should go up like an elevator, and each time it gets past a certain valve, it doesn't go down anymore. So that's why the blood keeps circulating, because the heart pushes it, which in turn pushes the blood down your foot, just pushing the blood up your foot. And as long as these valves are there, then as the blood gets up, it can't go back down. Well, if these valves are incompetent, which is what we call varicose veins, then in certain situations where you're upright, the blood just wants to stay in your legs. And so that same situation can happen in your pelvis. So if there's something that's keeping blood from getting out of your pelvis very well, then that can cause, quote, pelvic congestion syndrome.
Okay.
There's a couple different reasons why this can happen, and probably some reasons that we don't understand also. But one reason is varicosities of the gonadal veins, which is the ovarian veins. And so one classical treatment is embolizing the gonadal veins. And so interventional radiologists do that. I think it works in some people, not in others. So there's this other thing called May-Thurner syndrome, which is where the left common iliac vein is compressed by the left artery. We have an anatomical situation in our body where the aorta is like this and the vena cava is like this, and they split kind of like that. Okay. And so what happens is this vein is getting compressed by this artery. And there's no other way to do it. Like, somehow you got to arrange it. And so, no matter how you arrange it, some vein is going to be under. I guess if the veins all went on top, if they don't. So the veins go under the arteries. So what happens is sometimes this artery, for one reason or another, is particularly compressive of this vein. And that vein is the common drainage of the whole left side of the pelvis. Okay. The big vein. It's like the biggest vein in the body, other than the whole vena cava, which is the huge vein that goes up your abdomen. And so there are some people that have pain in the left side, mostly in the left side, because they have this, quote, May-Thurner syndrome. And interventional radiologists have diagnostic criteria for this. It can be seen on a CAT scan, and there's also some endo vessel ultrasounds that they do, where they put a catheter in the vein and they actually, some sort of ultrasonography that's on the end of the catheter. I don't know exactly how it works, but there are some criteria. And in people who truly have May-Thurner syndrome, the interventional radiologist can put a stent in that vein. It's basically like a scaffolding that holds the vein open.
Okay.
So now that artery that's going over the vein is kind of like pushed up because the vein is holding itself up by an internal scaffolding. Again, these are things that like, they work sometimes, not other times. The question is scaffolding going to clot off eventually? That's a big problem with endovenous prostheses. Effectively, is you're putting a piece of material inside a vein for the rest of your life. Does it really, if you do it when you're 30 years old, what's it look like when you're 70? You don't know.
Right.
So, and then I think there are some conditions where you literally just have venous malformations where a vein is very tightly wrapped around a nerve. And in neuropelviology, I deal with that sometimes. So sometimes people have sciatic pain, and it's a cyclic sciatica where every single time, when they're on their menstrual cycle, they have sciatic pain, but they don't have endometriosis, or they have endo, but it's not anywhere near the sciatic nerve. Some of those patients, the common iliac vein that comes off into the internal iliac vein, it gives off a couple veins that go over the top of the sciatic nerve, called the gluteal veins. They drain the buttocks. And in some people, those veins are really tightly around the nerve. They should be kind of loosely around the nerve, so there's plenty of fat in there, and it doesn't really, but occasionally you see it, and you can see that the nerve is really kind of tightly bound up by that vein. And so when blood flow is increased in the pelvis, that vein is kind of getting plump, and it's constricting the nerve and causing sciatic pain. So in that kind of circumstance, we can address that surgically. You can actually dissect out down to the sciatic nerve, and you can coagulate those veins and kind of like free up all the space around the nerve.
Okay.
And again, these are things that you have to kind of like intellectually reason out, that think that this probably is the case, and then you have to go look. There's almost no way to confirm or deny this by any preoperative imaging. You have to, that's kind of what neuropelviology is, like you intellectually figure out what must be going on, and then you go and look there surgically. It's very hard to confirm this with any kind of imaging study.
Right.
Maybe you can in some circumstances, but if the clinical situation tells you this thing may be there and the imaging study says it's not there, it still may be there.
Right.
So you still have to potentially go look.
Okay.
So pelvic congestion syndrome, like one of the sort of most effective ways of dealing with pelvic congestion syndrome is just to do a hysterectomy, and possibly even an oophorectomy. Like, unfortunately, of course, that's going to make someone unable to bear children, but the pain is often because of the high amount of blood flow through the pelvis. There is no uterus there anymore. The blood flow, the arterial blood flow into the pelvis is much reduced.
Okay.
And so that actually has a fair amount of effectiveness. Taking progesterone, which just causes the uterus to not cycle, get a very thin lining, and over time it's going to decrease blood flow to the uterus.
Okay.
That actually is also associated with improving pain from pudendal neuralgia, or excuse me, from pelvic congestion syndrome. So I think that just anything that's going to decrease blood flow in the uterus, in the pelvis, is going to make pelvic congestion syndrome less symptomatic. And so that's why hysterectomy can be helpful.
Right. We have a question also about peripheral neuropathy in the legs, hands, and feet, and whether this could also then be the cause of urinary incontinence.
Well, I mean, there's potentially a common pathway. So if you have peripheral neuropathy, that would imply that you have something that is causing a global injury to your small nerves in your body. So the most common one would be diabetes with poor blood sugar control. So people that have chronically high blood sugars will eventually injure their peripheral nerves, and they can in turn get bladder dysfunction from that also.
Okay.
There are other neurologic conditions like multiple sclerosis, or I think, I'm not a neurosurgeon or a neurologist, so I don't know what all these conditions are, but there are neurologic conditions that could cause both peripheral neuropathy and then in turn cause neuropathy in the pelvis also. So I don't think that peripheral neuropathy is, well, I think peripheral neuropathy can cause those things, but it's like the fact that your hand is has neuropathy is not causing your pelvis to
Yeah.
have neuropathy, but there's a common pathway to all both.
Okay. And what about stenosis of the spinal canal? Is that related to intermittent UTI symptoms at all?
I don't. I mean, I don't know that I absolutely know the answer to that. I mean, in order for it to be true, it would have to be in the sacral root. So if you had stenosis like at S2, S3, S4, then yes, potentially so. But
Okay.
you don't have any discs there, and you don't get herniated discs in your sacrum. So I think that that's uncommon. There is a condition called Tarlov cysts, which is it's almost like a herniation of the nerve sheath, and that exists in sacral nerve roots, and it happens within the bone of the sacrum, where you get kind of this bubble of fluid within the nerve. It's highly controversial over whether these cysts are pathological or not. There was one study that looked at the laterality of pudendal neuralgia, and then looked at the frequency of Tarlov cysts and the frequency of pudendal neuralgia. And it showed that Tarlov cysts are more common in people that have pudendal neuralgia than they are in people that don't have pudendal neuralgia. Okay. But the location of the Tarlov cyst did not seem to correlate to where the pudendal neuralgia was. So if they have pudendal neuralgia on the left side, they're more likely to have Tarlov cysts, but they're no more likely to have it on the left side than they are on the right side. Mm-hmm. And so what that would suggest is there may be a common pathway to pudendal neuralgia and Tarlov cysts, but the cyst itself does not seem to be causing the pain. Okay. We think, because you would have assumed that Tarlov cyst would be on the same side as the pain. Mm-hmm. I would think. So, yeah. There are surgeons that do surgery for Tarlov cysts. We get into these weird circumstances where you have these really weird conditions that are uncommon that most people don't know anything about. And always you have surgeons pop up that say they can fix it. Right. And they're not taking insurance, and they're charging a lot of money. Mm-hmm. I don't take insurance either, but I try not to charge too much. Actually, I don't charge nearly as much as some of my colleagues do. And I don't, there's not any strong evidence that particular surgery works. I'm kind of getting off on something, but on different stuff.
Well, on non-surgical techniques, people often talk about rewiring these neural pathways to kind of prevent this chronic pain. Can you talk a little bit about how that works and whether it's effective?
I don't know. I mean, it's a made-up idea. I mean, you're obviously not rewiring it. You only got one set of wires.
Not physically, but mentally.
Well, okay, there's different ideas there. So there's psychological rewiring. Mm-hmm. There's a difference between pain and suffering. Okay. Mm-hmm. Pain is a physiologic, neurologic phenomenon. Suffering is a psychological phenomenon. So it is possible to feel pain but not feel suffering. Mm-hmm. I mean, there's Shaolin monks that have figured that out. I mean, there's clearly people that have learned how to not suffer in the face of pain. I'm not saying it's easy. I don't know how to do it, but I'm telling you, given enough psychological indoctrination or learning or whatever, there seem to be people that are able to do that. Mm-hmm. So that is a certain kind of rewiring. I'm not sure it's achievable but it may be achievable to some extent by a lot of people. I don't know that it's achievable, to the point where, the Shaolin monk is hitting themselves over the head with a board and they say it doesn't hurt. Like, that's pretty intense, but if you can decrease the level of suffering by some sort of perceptive change, then that is something, and ultimately that's something that you work with a psychologist. Mm-hmm. But to the extent, can you rewire the actual neurologic impulses in your nerves? I don't know. I mean, there are people that claim to know, but I think that they're full of crap. I mean, I think to some extent, I mean, they're not maybe totally full of crap, but I don't think that that's a reliably reproducible thing you can do. Mm-hmm. But I do think there's medications that can decrease the intensity of nerve signals getting to your brain that mm-hmm. aren't just pain medications. They're literally affecting the nerves. Yeah. Now, Mark Passover does stuff with neurostimulation that I haven't gotten into yet, where you do seem to be able to create something called neuro regeneration or neuroremodulation, which I guess could be another term for what you're talking about. Mm-hmm. where by doing very high frequency nerve stimulation of nerves that are in pain, you seem to be able to cause a long-term impact on the nerve to where even when you turn that stimulation off, the nerve continues to function better. And
Okay.
so that does seem to be a concept of what you're talking about,
Mhm.
but it's experimental and not really proven, you know?
Okay. Do you work with a lot of patients that have chronic UTI and nerve problems? And if so, what are the outcomes like for those patients usually?
They're mixed. I mean, I don't know that I work with a lot of those patients. We work with some.
Hmm.
Uh, I think we can usually resolve the chronic UTI. I mean, if their nerve problems are secondary to their bladder constantly being inflamed,
Yeah.
if we can resolve the chronic UTI, then you probably over time the nerves can stop being irritated.
Okay.
You know, now if it's the other way around, where they don't have anything wrong with their bladder, their nerve problems are causing their bladder to hurt,
Yeah.
then you can pour antibiotics in that bladder till the end of time. It's not
Yeah.
going to fix like the problems in the nerves. So I don't really like to quote outcomes because I think that it's a mishmash of a million different things. I mean, if I can say I'm 50% successful at X patients, I'm 100% successful with half of them. You know,
Yeah.
it doesn't, and like there are individual patients that I see that I'm like, yeah, I probably can make you better because I can really figure out why I think this is going on. There are other patients I see where I I don't have any idea what's going on, and it's like if I do this, I just do something, it's probably not going to work.
Yeah.
And so like all I can do is say that like I can talk to an individual person and try to think about what is going on with them, and I may or may not come up with a good idea of what to do,
Right.
you know, and it's a lot better than just telling them to go away and I don't know what's wrong with you. You know, we will figure out some things and some things we won't figure out.